This webinar is presented by the Southern AIDS Coalition, along with our partner, the National Alliance of State and Territorial AIDS Directors. If you would like to download the slides, they are available on our website, southernaidscoalition.org. Just a couple of quick instructions. All attendees are in listen-only mode, but you can ask questions anytime using the chat feature, which you'll see in the window on the right of your screen. You may also email your questions to me at rcops@southernaidescoalition.org. Questions may not be submitted over the phone due to the large number of participants. When we get to the Q&A segment, we will read questions to be answered. If you're having trouble hearing us, please go to www.webex.com and click on the technical support link at the bottom of the page. Here is a quick graphic about how to ask a question. You can also chat us about how to use the system if you're having any difficulty. The webinar today is brought to you by the Southern AIDS Coalition. SAC is a regional organization comprised of a unique partnership of government representatives, community-based organizations, and people living with HIV and AIDS. We encourage everyone to visit our website, southernaidscoalition.org, to join our listserv and make use of the site, including the 2012 Southern States Manifesto. Today's presentation is made possible by the generous support of AIDS United through their Southern Reach initiative. So a special thanks to them, as well as our partner, NASTAD. The National Alliance of State and Territorial AIDS Directors is the nation's chief state health agency, represents the nation's chief state health agency staff who are responsible for administering HIV/AIDS and viral hepatitis healthcare, prevention, education, and supportive services. And they are also dedicated to reducing the incidence of HIV and AIDS and viral hepatitis infections in the U.S. and its territories by providing and supporting comprehensive, compassionate, and high-quality care to all people living with the disease and ensuring responsible public policy. We are also very thankful to NASTAD for sharing Amy with us. Our presenter, Amy Killelea, is the Senior Manager of Healthcare Access with NASTAD. Amy is truly the expert on all things healthcare reform, and she has worked tirelessly over the last few years to lead NASTAD's health reform implementation efforts, develop implementation resources, and provide assistance for state HIV/AIDS programs, working on policy recommendations and analysis to inform federal implementation. She also co-chairs the Federal AIDS Policy Partnership's HIV Healthcare Access Working Group. So we are very thankful to Amy for sharing her expertise with all of us. So here's what's ahead of us for today's webinar. In Part 1, Amy will cover the Affordable Care Act implementation timeline and decision points. And for Part 2, she will give implementation updates and highlight some strategies for states not yet expanding Medicaid. And I just want to be clear that, and I'm sure Amy will talk about this a little bit more, but we do believe that all states will eventually expand Medicaid, and SAC will continue advocating for that. But we also feel that in the meantime, it is helpful for states not yet expanding Medicaid to have a strategy for how to couple together the resources that are available and to provide care for low-income individuals. We will conclude with a wrap-up and Q&A session, and please note that this webinar is being recorded and will be available for review on our website within the next few days. At this point, we will hand it over to Amy.
Great, thank you. Thank you very much. It's a pleasure to be with you all this afternoon, and thank you to Rainey and the Southern AIDS Coalition. You've got the sort of outline of what we're going to talk about today, and with that, I think we'll just dive right in. So I want to start out talking just a brief update of some of the ACA timeline, what's sort of next up on the docket in terms of action items and decision points going forward. So next slide. So I'm not going to go through every box on this slide, but there are a couple things that I want to point out. The first is to sort of note that bigger sort of pinkish box there in the middle, and just note that federal funding and the decisions and conversations that are going on in Congress right now matters. And, we've already seen a pretty constrained federal budget picture. And I think it's important, we could spend, the rest of our time today talking about impact of federal spending on, not only HIV programs, but the range of sort of public health and other safety net programs. But I do just want to note that, those conversations really do matter and do impact states' ability to fully implement the Affordable Care Act. And I think what we're seeing now is a bit of a perfect storm in terms of, funding cuts to vital public health activities, agencies, and programs at a time where we're really asking our states to prepare for a very changing healthcare environment and landscape. So I do want to acknowledge that is a sort of challenging environment, but that's the environment we find ourselves in. And I would encourage everybody on this call to please stay engaged with the federal advocacy going on around full federal funding for the Ryan White program and for other public health and healthcare programs and agencies. The other thing that I want to point out, and I don't think I need to tell anyone on this call this, but we are at a very, very fast timeline. We see that the October 2013 date, which is when open enrollment for private insurance coverage through the marketplaces or exchanges begins, that is a mere less than 5 months away at this point. And the fact of the matter is, I feel very privileged right now to be able to give a webinar on the Affordable Care Act more than 3 years into the law's implementation. But because over the course of those 3 years, we saw, several near-death experiences essentially for the Affordable Care Act. We saw the first with the Supreme Court decision back in June, and then we saw the second on the November 2012 elections. And, the fact of the matter is that I think people woke up on November 7th, 2012 and said, oh gosh, this law is the law of the land, it's going to be implemented, and there's a lot to get done between now and, October when open enrollment starts, and then followed closely by January when coverage begins. So I think that states and the federal government are finding themselves with a whole lot to do over the next coming weeks and months. And I think, for the advocacy community and just for HIV providers, for people living with HIV, this means really, really trying to figure out where are the decision points, what are the many, many moving targets to watch for, because this stuff is going to move pretty quick. So next slide. So I want to quickly just go through some of the implementation decision points. And I think, big picture, what we've seen really since the beginning of the law's enactment is a federal policy choice, and perhaps somewhat influenced by politics as well, to really cede a lot of the implementation decision-making to the states. So certainly we've seen our fair share of federal regulations and then, congressional funding decisions, but many of the decisions around benefits, around the Medicaid expansion, for instance, and around some of the decisions with regard to marketplace, implementation and design, those decisions have been ceded to the states. And the fact, it's interesting, we're talking about, and to many of you are in southern states right now, and we've seen somewhat ironically, we saw, first the federal government cede decisions to the states, and now we are seeing many of those states, particularly in the South, really kick those decisions right back to the federal government. And we're going to talk a little bit about what that means, what that means for advocacy, what that means for implementation, and what to expect going forward. So next slide. As background, I want to jump into sort of the meat of what we're going to be talking about. And that's really thinking through, if you're in a state that is not yet expanding Medicaid, and Randy's absolutely right, the not yet there is sort of the key piece of that sentence. I think we fully believe that every state will eventually expand Medicaid because it makes economic sense, it makes public health sense, it makes individual health sense. But, we do need to be cognizant of the fact that we're going to see many states who are going to drag their feet a little bit on that. And I think that there are strategies to figure out how to maximize other pieces of the ACA. So next slide. So I think, before we jump into the details of the provisions, really to take a step back and think through, what are the three main sort of implementation questions, issues that's really going to determine the impact of the Affordable Care Act on Ryan White programs, on access to care for people living with HIV. And I think that those three questions can be sort of boiled down to these. The first is, will the ACA's insurance extensions be fully implemented in every state? And there, the question mark in many states is the Medicaid expansion. And we're going to talk a little bit more about what that means and where things stand right now. But that is a key sort of decision and a decision that's going to have an impact on what the ACA means. The second one, insurance coverage only gets you so far. How do we make sure that access to insurance through either Medicaid or the private insurance expansions actually translates to access to care? Will the benefits requirements for both the private insurance and Medicaid expansion meet HIV prevention, care, and treatment needs? And we'll talk a little bit about some movement on that, where we are on that. And then finally, and I think this is the sort of overarching question that the HIV community is confronted with right now and will continue to be as the ACA rolls out, will we be able to leverage the ACA at the same time that we preserve the Ryan White program expertise and models of care that everybody on this call has built over the past decade to really continue to make strides along the treatment cascade and to use the sort of ACA and the Ryan White program as a 1-2 punch in terms of really increasing access to care. So those are the three sort of overarching questions. Next slide. So before I jump into some of the implementation updates, I kind of want to step back and think about who we're talking about and what the impact of both the Medicaid expansion and then the private insurance expansion on people living with HIV. So this is actually from the most recent NASTAD National ADAP Monitoring Project annual report published back in January. And so this is just it's a national sample, so it's looking at ADAP clients served by income. So when we think about the Medicaid expansion, right, we're talking about expanding Medicaid to people with income up to 138% of the federal poverty level, about $15,000 a year for an individual. So next slide. So that is not an insignificant amount of people, right? And again, I think that at this point, people are well aware of the impact of the Medicaid expansion in terms of really turning Medicaid from a disability program into a health care program. So a whole lot of people who right now are receiving care through the Ryan White program and ADAP would be eligible for Medicaid in 2014 should their states expand Medicaid. Now, however, next slide. We know that despite the huge benefit and really a significant expansion of access to care for people who currently are not insured right now, many states are not going to be expanding Medicaid, at least not in 2014. So I just wanted to really put a sort of fine point on what this means, because this matters. This decision matters. In a state that doesn't expand Medicaid, we're essentially left with the status quo for Medicaid, right? So that's the traditional Medicaid on that far left. And that's a status quo that does not work particularly well for people living with HIV. That's a status quo that, again, as we said, it limits Medicaid to a disability program. And, the truth of it is that the very states that are not going to be expanding Medicaid in 2014 are the states with the strictest Medicaid eligibility criteria right now. So we're left with that for the time being. Now, on the other side, and we're going to really focus the rest of our time on this side, subsidies will be available to help people purchase private insurance. Now, the trick there and the gap there is that those subsidies, which are made up of the premium tax credits and then the cost-sharing subsidies, those subsidies are available for people with income between 100 and 400% FPL. And that's because the law was drafted with the idea that the Medicaid expansion would not be optional. It did not sort of envision the Supreme Court decision making the Medicaid expansion essentially optional. So what you have is that gap in the middle, and those are the people with income below 100% FPL. They can't qualify for traditional Medicaid because the eligibility standards are too strict, and they can't get the subsidies because they don't meet that 100% FPL threshold. And so I really want to focus today actually on that gap, because I think that there are definitely strategies that we can talk about in states that are not yet expanding Medicaid to at least mitigate that gap. Next slide. So I'm not going to actually spend a lot of time talking through this slide. I think at this point people have probably seen this slide there's just a couple of things to know. And I actually hesitate in even using this slide because I wouldn't want people to sort of get the impression that, that these colors and the state decisions are somehow are locked for now and all time. I think this represents a snapshot in time. And actually, we're already seeing movement on sort of both ways, actually, on state decisions with regard to the Medicaid expansion. But, this is the sort of current thinking right now on state decisions, whether or not to expand Medicaid. And as you can see, this South is very heavily yellow right now. And so it really speaks to the need to figure out what are the strategies if the state does not go forward with the Medicaid expansion in 2014. So next slide. So one thing that before we move off the sort of Medicaid expansion update and move into the marketplace reforms, I do want to just highlight, as we said, plenty of reasons the state will expand eventually, and I think the least of which is the federal government pays 100% of the expansion cost for the first 3 years. We're seeing a lot of movement on the advocacy side from hospital associations in particular, because the other reforms, particularly reductions in federal funding to safety net hospitals, are going to make it difficult for states not to expand, and hospital associations have really been important allies in the fight for Medicaid expansion in states, and I think will continue to do so. But the one that I want to just point out and have everybody sort of be aware of and looking at is this third bullet point. The states have significant flexibility around benefits for expansion population. This is another sort of theme from the federal government that we've seen, of really trying to give states a lot of leeway to design the Medicaid expansion in a way that works for their state. And I would urge everybody to really keep a close eye on Arkansas in particular. Arkansas has proposed to CMS and has gotten sort of initial green light approval for a plan in which it would expand Medicaid, but the state wants to use federal Medicaid funding to purchase private insurance for folks in the marketplace. So it's a little bit different way of doing the Medicaid expansion. I think that there are probably pluses and minuses in terms of ensuring protections for vulnerable populations. But if I'm in another state that might be on the fence about Medicaid expansion, or in a conservative state that has voiced concern or opposition to Medicaid expansion, I'm looking real hard at Arkansas, because so goes Arkansas, so goes a lot of those other conservative states who may want the federal money to expand Medicaid, but want to do it sort of their way. And we've already seen bills in the Texas legislature and others about very similar proposals that would structure the Medicaid expansion in that way. So I would keep an eye out for that. So next slide. So with that sort of overview of where we are in Medicaid expansion, I want to jump right into some of the private insurance reforms. And what I want to do is sort of highlight some of the biggest pieces and implications for people living with HIV and providers and programs, and then also as we go sort of highlight action steps, right? What people should look out for and sort of how to be involved. So I want to start out with thinking through who we're talking about again. So this is back to our ADAP client served by income. So next slide. So we saw on the Medicaid side, right, Medicaid would expand from 0 to 138% FPL. So if you were in a state that expands Medicaid, the subsidies would be available for those people over income for Medicaid and up to 400% FPL. Next slide. So if you're in a state that's not expanding Medicaid, I think we need to go back one slide. So if you're in a state that's not expanding Medicaid, we're really looking at people with income 100 to 400% FPL. Now, that's not an insignificant portion of the population if we just look at ADAP clients. So those are people who are going to be eligible for the federal subsidies, and we'll talk a little bit about that. But then I also want to talk about those people who are below 100% FPL. Where do they go? How can we make sure that they're able to access some of the ACA reforms? And we'll talk about that. I think that there are opportunities. So that's sort of the world of people that we're talking about when we talk about really maximizing the private insurance reforms in the marketplace. So next slide. So So let's jump right into the sort of anatomy of the exchanges, marketplaces, and what it means in terms of implementation going forward and access to care going forward. So at the outset, states had a sort of three choices with 2-0 adventure in terms of implementation of the marketplace. States could set up their own state-based exchange or marketplace. You see those in the blue there. And states could sort of throw up their hands and say, federal government, we want you to design and implement and oversee the exchange. You see many, many states there, many of them in the South, in yellow there. And then you start sort of the hybrid choice of states that have opted for a partnership model where the federal government is really designing and implementing the exchange or marketplace, but the state has retained some functions. So that's kind of where we are. And for the rest of this presentation, because we're really talking about, and I don't think it's any coincidence, many of the states that are not expanding Medicaid are also the states that are have gone with the federally facilitated exchange. And I think there are actually some opportunities there going forward. So next slide. So regardless of sort of which adventure your state chose in terms of exchange implementation, at the end of the day, it shouldn't really change all that dramatically the consumer experience, right? The applicant's experience of interacting with the exchange. And that's because, there are certain sort of core features that define what an exchange is. That the federal government has set out via the law and then all of the implementing regulations that have been set out. So, across the board, no matter what kind of exchange you have, every exchange has to have some sort of outreach and patient navigator program, has to make sure that they've got that component in place. Every exchange has to have some way to certify the plans that are going to be sold in the exchange, some way to make sure that the plans that are going to be sold meet all of the ACA criteria. And that stuff includes criteria that the HIV community is going to be very interested in following and making sure is strong, including network adequacy standards, so standards that require a certain amount of providers to be, and types of providers, and we'll talk a little bit more about that. Every exchange, and this is a real theme, every exchange has to have a simple application process that allows someone to apply for both Medicaid and the insurance subsidies. So, those sort of core features of the exchange are going to exist in the federally facilitated exchanges as well as the state-based and partnership exchanges. So next slide. So I wanted to kind of walk through, what the idea behind the exchange, what it's actually supposed to look like on the ground. I think it's easy to sort of get lost in the abstract concept of the exchange marketplace. So this is actually a screenshot from Nevada. Nevada is a state that went with a state-based exchange. So they're sort of far ahead of the game in terms of the development of the website portal. And this is something that, should not be dissimilar to what the federal government is right now very quickly creating for the 30-some-odd states in which the federal government will be running the exchange. So a couple of things to sort of point out. This website portal, the idea behind it is that you start with the applicant there who's able to access the online application, which we'll talk about, and plug in all the sort of income information in a very simple way online. And for most people, the exchange really envisions a real-time eligibility decision using sort of this federal data services hub. That's the stuff that would happen kind of behind the scenes. So if we just kind of back up and think about it from the consumer perspective, what will the applicant sort of see and experience? The idea is a very simple website portal application process where you get your eligibility decision, in most cases, in real time, and then you're allowed to also figure out, okay, I'm eligible for a qualified health plan for private insurance, I'm eligible for this amount of federal subsidies, and which plan makes sense for me based on that. So that's sort of the idea and thinking behind the exchange. And I guess the thing to point out in terms of those of you, and most of you who are in the federally facilitated exchange states, as we said, everybody's kind of moving a mile a minute to get ready for October. So some of this website portal stuff will not be seen until much later. I don't think we have an exact date which that sort of information will be available, but that's something to stay tuned for. I don't think it'll be vastly different from what Nevada has done here. but it's something to keep an eye out for. So next slide. So another piece to keep an eye out for and to be thinking of is, and really thinking through, what is the consumer experience, how to prepare people living with HIV. I know many of you are calling in from community-based organizations. Many of you are probably case managers. And part of the functions of case managers and anyone sort of on the front lines in terms of that sort of benefits counseling that's already happening is figuring out how to help consumer clients navigate this sort of application enrollment process. The idea behind the application enrollment process is really simplicity. And that has been sort of a theme in terms of the regulations and then the sort of marketing of the website portal and the application. So we've actually already seen and actually next slide, HHS has come out with a streamlined application, and this is actually the second iteration. The first one was 20-some pages and got a lot of sort of consumer criticism of, how can it be simple if it's 25 pages? So they sort of went back to the drawing board, made it much shorter. So this is just taking a couple of different pieces from that streamlined application to just give you a sense of what the application is going to be asking and how it's going to be documenting income for folks. And I'm not going to go through this application in great detail. I would urge folks on the phone to take a look at it. It's up on HHS website. And the reason I think it's important to take a look at it, this is what your clients, this is what people living with HIV, anyone who's going to be signing up for the subsidized private insurance is going to be looking at. So I would sort of familiarize yourself now to really help in that, in making sure that application process is in fact streamlined and simple. So next slide. So, the other question, we've got a streamlined application process, right? But application to what? What does that mean? And I think this is something that the HIV community and others have really followed closely in terms of the benefits requirements for private insurance. So, what we saw, and these decisions are now final, what we saw, and this is the theme that we were talking about earlier of the federal government really feeding a lot of the decision-making around implementation to the states. And we saw that happen with the benefits requirements. We saw in the law the 10 very broad categories of essential health benefits that every plan sold in the individual and small group market, so including those sold through the marketplace, had to cover. And what I think we had hoped for was some sort of federal national definition of the services that made up those 10 very, very broad categories. And we didn't see that. The federal government went a different route, and in feeding sort of that decision-making to the states, adopted a benchmark approach. So states had from 10 benchmark options, and those were plans that are already existing in the private insurance market to choose from as the standard plan that all of the plans sold within that state's marketplace was going to have to meet in terms of scope of coverage for those 10 categories. And so those decisions are final. I would urge folks, if you haven't already, to go on the HHS, the SOCIA website, and look up your state's plan and get a sense of what the scope of coverage is. Most states went with a small group plan for their benchmark plan. And, I think in terms of the takeaways from that, right? I think it was disappointing that we didn't really get the federal regulation on the actual plan content requirements. But the fact of the matter is, we've got a status quo of the small group market, right? So while I think everybody hopes for some national federal standards and some elimination of the state-by-state disparity and variation, the small group market is not terrible. I think it's something that we can work with, and I think in terms of access to regular care and access to insurance coverage, it's definitely going to be a positive. I think, in terms of what to watch out for, because of this sort of theme of little federal regulation around spend content requirements, we also saw that sort of also seep into requirements around things like service limits and utilization management, such as prior authorization. That stuff is going to continue. So that's going to be, I think it's going to be an imperative for anyone who is helping clients figure out what plan is best for them to really keep an eye out for and to make sure that the plans are not using service limits or things like prior authorization in a way that really bars people living with HIV or really any complex, expensive condition from accessing care and coverage. That would apply to prescription drug coverage too. We saw some positive language in the final regulations on prescription drug coverage, and the takeaway is that the prescription drug coverage for the plans that are sold within the marketplace have to cover the same amount of drugs as the benchmark plan. And long and short of it is that's a good standard. It's not bad. The benchmark plans, for the most part, cover all of the antiretroviral drugs and HIV medications that people need. So again, what to watch for, we'll get most of the drugs covered, but what to watch for is prior authorization attached to those drugs, or what tier in terms of the formulary tier those drugs fall on, and what cost sharing is associated with them. So that's kind of the update on essential health benefits, but I do want to talk about one benefit in particular that I think is important for people living with HIV. Next slide. And that's case management. And I think that case management offers sort of a useful lens to think about the larger overarching theme that insurance coverage does not replace public health. Insurance coverage does not replace the Ryan-White program. Even with insurance coverage, there are going to be a range of these vital enabling services that are essential in getting people in care and keeping them in care, but they're not part of the private insurance sort of realm and world of reimbursable covered services. In case management, I think is a perfect example of that. If you look at private insurance, just look at your benchmark plan and figure out, what case management is covered. This is not the case management that the Ryan-White program has really, defined and built over the years. This is a much sort of tuned down definition of case management in terms of usually being just periodic phone calls to discuss appointments, maybe assist in finding services, but really going to that far side of Ryan-White program, nothing like the more intensive medical and non-medical case management, including things like treatment adherence counseling. So I think the takeaway there, and I won't really get into Medicaid, that's a sort of state-by-state variation in terms of what Medicaid covers for case management, but it's limited. So I think the takeaway there is that, even with folks moving into private insurance coverage, the Ryan-White program is going to be absolutely essential in terms of continuing to provide that case management that simply is not part of the private insurance world. So next slide. So the other thing to keep an eye out for is, and this is closely related, I think, to benefits coverage. So, okay, you make sure you've got your HIV medications, your core services for people living with HIV. Now, are providers included in those provider networks? And that's going to be a sort of ongoing conversation and really essential to make sure, again, that access to insurance is translating to access to care. So we saw federal requirements with regard to provider network adequacy, the requirements for who all have to make up those provider networks for the plans sold through exchanges. And we saw requirements that the plans have to contract with what's called essential community providers. And that definition includes explicitly Ryan-White providers, so that was definitely good. Now, sort of the negative side was that the federal standards with regard to how many of these essential community providers that plans have to contract with are not great. So, I think that it's going to be a sort of state-by-state effort to figure out, who are the plans that are going to be sold in the marketplace, what are their provider networks, and how do we make sure that HIV providers are hooked up, linked in, are communicating with those plans. And again, if you're in a federally facilitated marketplace state, and I know that many of you on this call are, this is a tough one, because we don't yet know what the plans are. And looking at the federal government's timeline, it is going to be very, very tight, and we may not know the actual plans that will be sold within those marketplaces until very close to the October 1st open enrollment deadline. So, in the meantime, I would urge folks on this line, the Department of Health and Human Services has actually published a non-exhaustive database of these essential community providers. It's searchable by state, and you can also search Ryan-White provider. As a first step, I would look at that database and see, are the HIV providers that you would consider sort of essential to be part of these networks on that list? If they're not, I think that there are avenues to alert HHS of those gaps. And then I think it's going to be a state effort to really figure out, how can we make sure that the plans know about those essential community providers and are contracting with them. So next slide. So we talked about sort of the application process, the benefits of provider networks, and I think the other key piece of making sure that, access to insurance is meaningful is to make sure that insurance is affordable. And this, I think, is the real key to making sure that we are maximizing the private insurance extension for people living with HIV. And I'm not going to, there are many, actually, provisions that really address the affordability issue for private insurance. And what I want to focus on today is two of them. And I would consider these to be the sort of two biggest affordability provisions. The first one is the advanced premium tax credit. And that's available for folks with income between 100 and 400% federal poverty level. So, think back to our ADAP plans by income. This is a lot of people who are going to be eligible for this tax credit. The amount of the tax credit is going to be the difference between a benchmark premium, so it'll be like a known plan, and you'll use that premium as your benchmark, and the credit is the difference between that benchmark premium and then the taxpayer, so the applicant, the client's expected contribution. And all expected contribution is the amount that the federal government expects somebody to sort of kick in for their own premiums. It's sliding scale, and it's based on income. It increases from 2% to 9.5% based on income. So the income eligibility is, for the most part, going to be based on end-of-year tax filings, but and we can talk about this in the Q&A as well. Pay stubs and other documentation at the front end will be allowed to demonstrate income. The tax credits are paid in advance. They're paid directly to the plan, so no checks going to clients. And then at the end of the year, come tax time, the member, the client, is responsible for any overpayment. So this actually, I think, for any case managers on the phone who are going to be walking clients through this, very, very important to, throughout the entire year, to be reporting any changes in income, because come tax time, if a person has overestimated the amount that they're due for the tax credit, they will have to pay that money back to the federal government. So that's sort of tax credits in a nutshell. The other major piece, right, you've got premiums taken care of, but then you also have, cost sharing that is often prohibited in terms of access to affordable insurance. So the federal government has also put in place cost sharing reductions, and those are for people with a little bit lower income, between 100 and 250% FPL. And, the cost sharing reductions work sort of similarly to the premium tax credit in that it's a behind-the-scenes sort of deal. With how they're implemented is that the reductions just increase the actuarial value of the plan. And all actuarial value is a measure of is the plan's generosity. So how much the plan pays for services versus how much is foisted onto the consumer. So it's actually a pretty simple way to implement these cost sharing reductions is to have the federal government just pay directly to the plans and say, plans, you have to make your product for veterans. So that's another thing to keep an eye on. I think that the one-two punch of the premium tax credits and the cost sharing reductions are going to be hugely significant in terms of actually making insurance affordable for. Next slide. So I'm not going to repeat too much. This is just kind of a visual representation of how the premium tax credits cost sharing reductions work. You apply through that streamlined application that we looked at. And you can apply through that website exchange portal, and then the payments directly to the plan. So one thing I do want to point out, particularly on the cost sharing reductions, so there's a way in which many parts of the ACA were written, designed, and are being implemented in a way that's focused on your sort of healthy uninsured person, right? And so I think we know that even with cost sharing reductions, there are still going to be outstanding cost obligations. And particularly, I urge you to go to your benchmark plan look up the formulary, look up the HIV medications and where they fall in terms of formulary tiers. They fall on pretty high tiers that come pretty significant cost-sharing obligations. So even with the cost-sharing reductions, there may be outstanding obligations. And ADAP can cover that amount that's not covered by federal subsidy. And I know, many of you are in states where your ADAP runway program has an insurance purchasing program. So I would urge you to sort of look at what that program does, what the eligibility criteria are, because I think we're going to see a huge role for a ramp-up of ADAP insurance purchasing to make sure that, and this is particularly true in states that are not expanding Medicaid, to make sure that we are really maximizing that private insurance expansion. And I would say, too, that goes forward, when we think about those people who are under 100% FPL, I think in those states it's even more important to really think through the ability and opportunity for ADAP insurance purchasing programs to help mitigate that Medicaid gap by getting those people under 100% FPL into federal marketplace coverage. And we can talk a little bit more if people have questions about that. But that's something that I know that many states many programs who are in states that are not expanding Medicaid are really looking to their insurance purchasing programs to help lessen that gap. Next slide. So, through concerns issues going forward. We talked about that first one, particularly important for people under 100% FPL. I would say for folks on this call, we're going to see a whole lot of action from the federal government in terms of guidance and other implementation activities for those federally facilitated marketplaces in the coming weeks and months. CMS, I know, has had a series of stakeholder calls that are state-specific. I would urge folks to participate on those stakeholder calls. I think there's going to be many from now until October. And then I would also monitor the plan options, monitor when the plans are identified who are going to be sold in the marketplace, and be prepared to sort of weigh in those designs when they're available. And then finally, I think there's a huge role to really make sure that clients are prepared for private insurance coverage. And I want to focus on that first one for a second, and I think this is true of many people in this country writ large. Many people, even though they should, just do not interact with the IRS for whatever reason. They do not file their federal taxes. And the fact of the matter is you can enroll, you can apply for these advanced premium tax credits with your pay stubs, right, with other documentation of income. However, it is a premium tax credit. It is imperative, it is essential for people to file their federal taxes for the year in which they receive that premium tax credit. So I think that it's not too soon to be urging clients to file their federal taxes, to think about their federal taxes, to start identifying low-income federal tax clinics and other help there, because there are many resources in that area. But I think that's going to be important going forward. And then finally, client outreach and education. And that's actually the topic that I want to end with to talk about some of those opportunities. Next slide. So, I think that there are probably many more than these four sort of examples of consumer outreach and enrollment through the ACA. I want to spend a little bit of time talking about the Patient Navigator program. The federally facilitated exchange states, the federal government will be running that program, and we saw the funding opportunity announcement released about a month ago now, with a due date of June 7th. So, I think sort of long and short some takeaways from that. Number one, there's not enough money dedicated to that program. I think we know that. So it's great. It's going to be very helpful, but there are going to be gaps. There are going to be people who are going to be doing this outreach and enrollment who are not going to get the grant to do it. And the other takeaway is that I think that there's concern among the HIV advocacy community that the FOA does not carve a space out for organizations and providers with population-specific expertise. And I think that was a bit of a concern. I think one way around that is to apply as part of a consortium. And I know that in many states, The organization efforts are well underway to try to get together a whole bunch of community-based organizations that have all together a very wide sort of reach and different expertise. So I think, step one is to figure out in your state, who are the other players, who's going after this grant. And in many states, that will be your sort of low-income healthcare advocacy network or coalition. They might be organizing that effort. So I would really make time to figure out, who is applying. And then even after that, once the grants are rolled out in August, to figure out who was granted those, who received those grants, to figure out what are the opportunities for coordination. Another thing on the patient navigator side to keep an eye out on is, we've been urging for access to some of the training that might be associated with the program, even for folks who don't actually receive a grant award, and to be determined on whether or not that will be available. But I think, the takeaway there, outside of the patient navigator program, right, you're going to see other training and outreach resources pop up in your state. And I think it's important to sort of figure out the landscape of those training resources and figure out, where it's possible, where you don't have to recreate the wheel, where you can take a state or federal training resource and tweak it for your own community, for people living with HIV. And I think, the kind of theme of we're all in this together and information sharing wherever possible is going to be incredibly important going forward. So, I would definitely keep an eye on the Patient Navigator program, both the grant opportunity, which again due June 7th, and the opportunity to sort of access that training or other training, even if someone doesn't receive a grant. And the other thing, which is very new that I just want to point out, is that community health centers just very recently, it was announced, will receive $150 million in grants to do this outreach and enrollment, which I think, we've been talking for a long time now about inroads and relationships with community health centers, but we see time and time again that the ACA really puts its thumb on the scale in terms of the role of community health centers. And for outreach and enrollment, I think this is another key area, and it's going to be very important to make sure that community health centers are linked up with HIV programs so that they're providing that information that is going to be, vital and helpful for people living with HIV who are enrolling into new coverage options. So next slide. So, I think beyond the ACA outreach and enrollment resources, I think the next kind of question is, where do HIV providers sort of fit in, right? And I think that boils down to how will clients know, number one, what they're eligible for, and then enroll in the plan that makes sense for them. And I think this is not dissimilar to the Medicare Part D experience, except on a much larger scale. So, I think our role going forward in a conversation really in your organization, in your state is, what does plan analysis look like? What is the role of HIV programs, case managers, and ADAP in that sort of plan analysis? Particularly, if we're thinking through how are we going to maximize access to care in states that don't expand Medicaid through this private insurance, we have to make sure that people are enrolling in the private insurance that makes sense for them, and that includes the prescription drug formulary that makes sense, the scope of benefits that makes sense, the cost-sharing design, and the premium tax credit and cost-sharing that makes sense, and the provider networks. And those are all sort of questions that we're going to have to be dealt with when we know the scope of the plans that are going to be out there. But I think that speaks to the role of, HIV programs, providers, case managers, community-based organizations going forward to be a part of that process in your state. So next slide. So I'm actually going to end with this one, and I just want to end on a sort of the importance of local planning and preparation for health reform. And, I think we all find ourselves in a pretty changing healthcare environment, and given the very tight timeline from now until October, we're going to see a lot of these changes and implementation, decision-making happen on a very, very tight timeline, sort of rapid-fire succession. And I think, the role of the local provider is essential in that changing healthcare environment to make sure that, we're really leveraging the ACA private insurance expansions in particular, and that providers are prepared to sort of operate in this new world, and that includes being prepared, to bill for services, being prepared to figure out, what are the vital enabling services that aren't going to be covered by insurance extension, and what is that provider's role. And then the safety net, the relationship with safety net providers, I think, becomes even more important when we think through the accountability issues. Is community health centers are getting a whole lot of federal money for ACA implementation activities and expansion activities. What is their role in being accountable for provision of HIV services? So, I sort of want to end on that, sort of bringing it to the local preparation, because I think there are a lot of challenges and questions going forward, but it really does have to start with, what is the impact and what are the action steps that folks can start taking on the local level. So I think I'm going to end there and turn it over to questions. I know we've covered a lot and not a lot of time, so we can get to questions, and if folks have follow-up questions, I think my email is on a resource slide, so please feel free to email me as well.
So I just want to give a big thank you to Amy. Thank you so much for your time and all the information you provided and the thoughtful presentation. And also, I just want to thank all of you for calling in. We really appreciate your input and your participation. And so you'll see on this slide is Amy's contact information if you would like to follow up with her directly. And also, all of the sites that she listed are excellent resources for health reform information. And so now I just want to go into the questions. So we've already received a few. Amy, one of the questions was about when you showed the slide with the contact, with the sample form that's being developed, and there was a question about what website that was from, and I believe you said that it was HHS.
Yes. I am more than happy to put it up. I believe it's on CCIO's website. That's CCIIO. It's the Center for Consumer Information and Insurance Oversight. And I have a link to it, which I can send for any of you can send out. But I would look at the CCIO's website for that.
Okay, great. And okay, so our next question, we had one that was in reference to, I believe it's the pie chart on slide 15. The Ryan White program looking ahead to 2014, and it said, in reference to that slide, can Ryan White Part A provide financial assistance, health insurance assistance, to enable people living with HIV to use QHP, much the same as ADAP will be able to assist? For example, is such assistance from Ryan White assistance allowable, the same as assistance from Ryan White ADAP?
Yes, so my understanding is that, yes, and I think actually this speaks to a larger point of, in many ways, when we're talking about increased access to insurance coverage through, the ACA, through the marketplace, we're not talking about reinventing the wheel. I mean, there are many states with incredibly comprehensive and robust insurance purchasing programs right now, including, state-run programs that help people access private insurance, as well as Part A's that are funding that insurance purchasing function too. So that's definitely a role that I think for Part A's going forward. And I think, probably a closely related point is that the coordination between, the Part B and Part A on that point is probably going to increase necessarily so, over the coming weeks and months as we try to coordinate that insurance purchasing function.
Okay. Thank you, Amy. So one of the other questions, when you were talking about the tax credits, and you mentioned that it would be important for clients to keep their income information updated to avoid having to pay out a pocket for tax credits in the year, there was a question about to whom was the client to be updating their income information with to avoid the overpayment scenario. I believe you were talking about case managers.
Well, so it'll be the same process for how you apply for the tax credit. So you apply through the marketplace, and it'll be the same process that you update your income, because it's the marketplace, the exchange, that will be sort of in charge of those income eligibility decisions. So it's that same process. And in fact, there will be information to consumers from the marketplace, that goes with the application consumer information about how to and when to update, the federal government about that.
Great. So one of the other questions from one of our listeners in Illinois is there a plan to handle comparisons when there may be over 120 plans in a particular state marketplace? Can you speak to that at all?
Yeah, I think that's a really good point, and something to keep in mind. Like, as I said, we've seen this before in terms of Medicare Part D and even the private insurance, although limited, that's available in some states right now, but never on this scale. So I know, Illinois has identified 120 plans. We don't yet know that the numbers of the plans that will be offered in the other states, it could be significant. So, I think that from NASTAD's perspective, we are very interested in figuring out how to and what tools to develop to sort of aid in that plan comparison, and particularly from NASTAD's perspective, aimed at age-card assistance programs to really help them figure out what the landscape is for their clients and where their insurance purchasing program sort of fits into that. But I think it's going to be challenging, even with good templates and resources. And in terms of information sharing, I think that there are other organizations who will be engaged in trying to develop similar plan templates to just be able to quickly figure out, all right, here are the 5 things that I'm looking for to make sure that the plan is right for me, for this person, for this client. And I would keep an eye out for that. But I think it's going to be challenging. There are going to be a lot of plans to be analyzing.
Okay, that's really helpful, Amy. Another one of our listeners wanted to know if you could talk a little bit more about a consumer who might be eligible for both cost sharing and also to get the tax credit. Do we know how much a consumer might be left to cover after receiving both?
So that is a good question. Let's see. So it's difficult to make those kind of predictions because it is going to depend on the plans offered in your state. And one of the reasons why it's very frustrating to be in a state that has not yet identified the plans that are going to be sold is that we don't yet know the cost. So I know that it's hard to plan in that environment, but I would urge folks to look in terms of trying to estimate, what some of these things could look like. NASTAD has actually put together an issue brief on the advanced premium tax credit and cost sharing subsidies, including some case studies of what that could look like. And the fact of the matter, it's going to vary depending on your income. So with a very low income, it'll depend on your the amount that expected contribution from the individual is going to be a lot less than someone who's making like 350% FPL. So I guess in terms of actual numbers, it's going to really depend on what the cost of those plans that are going to end up sold on the marketplace. But for like back of the envelope kind of estimates just based on some case studies, I would urge you to look at NASTAD's brief to start with, walking through some of that, and that's available up on our website.
Amy, you'll have to send us some of those links, and we'll send it out to all the listeners. I think that could be really helpful. One of the other questions is about the overlap of prescription drug coverage, and will there be any overlap between ADAP and private insurance?
Well, so overlap, I think that in terms of the initial analysis of the benchmark plans and the plans, the benchmark plans and the plans sold in the marketplace, for the most part, will cover the ADAP-covered drug. So in terms of comparability, I think we've already seen and we're going to see that the formularies are going to be comparable in terms of actual drugs covered, which is why, I think what we're going to see in many states is a move from ADAP full pay for drugs, right, where ADAP is paying someone who's uninsured and they're paying the full pay cost of drugs, to ADAP insurance purchasing to pay the person's, unsubsidized premiums cost sharing as folks move on to insurance, because those drugs are largely going to be covered. Now, the sort of trick there is, what is the cost sharing attached to the coverage of those drugs? Is there prior authorization? I think there's limits to look for. But for the most part, what we've seen is that the formularies are going to be comparable to ADAP.
I think that covers most of the questions that we can cover during this time. And if anyone out there, if your questions were not answered, we will try to follow up with you after the call. And I just want to say that we really appreciate all of you calling in. A recording of the webinar and the slides will be available in a few days. And you'll also receive a very short 5-question survey via email, and that will help us to know what kind of information is helpful to you in the future. So we ask that you please fill that out as well. So all of those things being said, I will conclude our webinar. And thanks again, everyone, for participating. And thank you, Amy.
Thank you.